This last session is a format that we have not used before for PAME, and it's a very appropriate one for the last session of the day because it really looks to the future of the field. Our trainees are the future of our field, and so this session was developed by a committee that reviewed all of the abstracts for the AES meeting that had any relationship to the to mortality and epilepsy, and was being presented by a trainee, a junior investigator, a trainee, and the committee chose what they felt were the top abstracts from that group, and so we were going to have each of the 6 winners come up and give a talk, and this will be accompanied by an award, research award. So congratulate all of them. And before we start, I'd like to introduce Lisa Cotton, who is a board member of Cure Epilepsy, and she's going to start by describing for us how she got to this.
Hi, everyone. It has truly been a pleasure to be part of today's discussions, and it's always so inspiring to be in a room full of parents and advocates and experts in the field. I'm here today because 6 years ago, on April 19th, 2015, we lost our beautiful daughter, Vivian. There's not a day that goes by that we don't miss her blue eyes or wish that we could hold her again. Vivian was only with us for 18 months, and sadly, about half of that was spent in and out of intensive care units. Through that experience, we discovered how challenging it is to navigate the healthcare system, especially with a medically complex child who required care from multiple specialties. It's Vivian's story that led me to become passionate about research and made me realize how important it is that we continue to fight for new therapies, innovative treatments, and of course, a cure. Our little fighter Vivian came into this world fast and without warning on November 2nd, 2013, when I was just 27 weeks pregnant and set to embark that morning on a 5-hour drive to our new home in Michigan. I went into spontaneous labor due to an incompetent cervix, and she was born within an hour of us arriving at the ER. We were in total shock, but I was just so happy and relieved that she was with us and doing well after such a traumatic birth. Aside from having to scramble for temporary housing, those first 24 hours after her birth, or 48 hours after her birth, were going well. She was a good size for her age. She was about 3 pounds, which was large for a preemie. However, things quickly took a turn for the worse when we discovered that she had developed a grade 4 brain bleed, which eventually resulted in shunted hydrocephalus, and likely the cause of her eventual seizures. As time went on, Vivian developed a host of complications. In her short time with us, she had 2 shunt revisions, chronic lung disease, pulmonary hypertension, a hole in her heart, kidney reflux, cataracts, a blood clot in her splenic vein, 2 bouts of pancreatitis, multiple pseudocysts, countless infections, and 13 surgeries. Vivian had many challenging complications during her short life, but I can absolutely say that epilepsy was the most devastating to her and is what impacted us as a family the most. We, like so many others, were not very well informed on how seizures could manifest. We were told by her neurosurgeon that seizures were a possible side effect of the shunt, but in the beginning they were so subtle we didn't realize that she was even having them. Admittedly, just 8 years ago, my vision of a seizure was someone actually convulsing violently. In her case, at times the seizures were nearly impossible to detect without an EEG, and the only noticeable change were her lips turning blue, which was obviously terrifying. When she was finally diagnosed with epilepsy, it had gone untreated for months, undoubtedly affecting her mental and physical development. It was then that we embarked on the treacherous road that so many other parents do: contradicting diagnoses, doctor's visits, EEGs, failed medication after failed medication, and in Vivian's case, several ER visits where she would go status epilepticus and nothing short of propofol would stop it. People's experiences with epilepsy vary widely, but for a case as severe as ours, we lived in what you might call an epilepsy prison. You're in a constant state of hypervigilance, looking for signs of another seizure. You develop a fear of taking your eyes off your child for more than a few seconds, fear of ever traveling too far from a hospital, and often fear of sleeping in a different room or even sleeping at all. As we've heard today, the effect epilepsy has on family members is so incredibly real and difficult. Vivian's sister Caroline learned to quietly retreat into another room while we would be hovering over her trying to comfort or record a seizure or call 911. My husband and I struggled for years, which was with what likely was PTSD with lingering symptoms still. It took us years to wean ourselves off anti-anxiety medication, which is in and of itself a traumatic process. My 9-year-old daughter still has bouts of profound sadness and heightened fear of illness or visits to healthcare facilities. So we look to all of you in this room and online to help us solve this complex illness. It's your hard work and dedication that has made breakthroughs in medicine and forging the trail of discovery that so that others may follow. I have said this before, and I think it deserves to be repeated. Research for us is hope. For those of us who feel hopeless, it is the light in the darkness we have been wandering in for far too long. Research brings the promise of a life that doesn't consist of a heartbreaking sadness after the 5th, 6th, and 7th medication, won't control the seizures, or maybe a life where there is less trial and error, with medications and more precise therapeutic protocols, a life where you don't live in fear of the next seizure being the last terrifying moment you spend with your child. While Vivian and countless others are no longer with us, we must continue to fight for the families who still struggle and many more that will come after them. We are so grateful for the advocates, clinicians, researchers, and families who share our mission and continue this fight. And of course, PAME for bringing us all together today. Thank you so much.
Thank you very much, Lisa. Our first scientific talk is from Amir Aschner. He is a research associate at the Hospital for Sick Children in Toronto, Ontario. If you could come up.
Thank you. Good afternoon. I'd like to start by thanking the Planning Committee for this opportunity to share some preliminary observations we've made investigating risk factors for SUDEP in Dravet syndrome. Here are the funding sources for our various partners, and we have no disclosures to report. So as this audience likely well knows, Dravet syndrome is associated with greatly increased mortality rates compared to the general epilepsy population. And this includes higher rates of SUDEP, which is the leading cause of epilepsy-related mortality. And as we heard earlier this morning from some very fantastic talks, there are some risk factors for SUDEP that have been identified among the general epilepsy population. But to my knowledge, what is not known is whether the weight of these various risk factors holds equal across the various epilepsy syndromes. And so with that in mind, we set out to identify potential risk factors for SUDEP in Dravet syndrome with the hope of identifying potential preventative treatments for those at greatest risk. This was very much a collaborative effort between our group and the Canadian Pediatric Surveillance Network, NASR based at NYU, and our partners at the University of Melbourne. And we were able to collect retrospectively cases of SUDEP in Dravet syndrome, and really, truly a wealth of data, as the talks we heard on registries earlier today point out. And this data included, when available, autopsy data and witness statements regarding circumstances around death. We were able to identify 26 cases of SUDEP in between these three registries. And over 80% of this cohort were definite plus, or probable SUDEP cases. And all of these cases were classified by consensus by 2 epileptologists. Many of the characteristics of this cohort are similar to what has been reported previously in the literature, and this includes relative gender parity and very high rates of reports of early onset of seizure before 1 year of age, multiple seizure types presenting, and a confirmed SCN1A mutation. Likewise, many of the circumstances around the SUDEP were typical of what we see in the literature, including that the majority of cases were unwitnessed, 65% of cases were found in bed, and over half of the cases were found in prone positions. This cohort was generally relatively healthy, on the other hand, apart from their epilepsy. In terms of respiratory comorbidities, there were 2 cases of asthma, 1 of lung disease, and otherwise very few reported cases of any conditions, apart from a history of apnea during seizures, in which there were 42% of cases. And in terms of cardiac comorbidities, there were very few cases that reported serious cardiac conditions. Because we know that most SUDEP occurs at night or in bed, we were of course very interested in the behaviors regarding sleep. And of our cohort, over half reported either sharing a bed or sharing a room most or all of the time. And of these 54 cases, 14 individuals, unfortunately, 6 of those 14 cases, the SUDEP actually occurred while the individual was awake, so it did not occur in bed or at night. Of the remaining 8, 57%, there was no evidence in witness statements that there was any change in their routine. And this speaks to the idea that although there is evidence that these behaviors are useful at preventing death, observation during sleep alone is not necessarily enough. One of the most startling observations we made in this cohort was that SUDEP tends to occur earlier in life in this syndrome. So in blue in this plot is our cohort, plotted on the x-axis is their life years when they died. And we found that there was a median age of death of 8.5 years old. From a couple of reports in the literature, we were able to combine a couple of cohorts and calculate a median age at death in this syndrome to be a startling 4.5 years old. And this is compared to population-based reports of SUDEP in the general epilepsy population, where the median age ranges between 23 and 50 years old. So there's really a dramatic difference. We also noted that of our cohort, over a third of the individuals reported a decrease in their seizure frequency over the preceding 6 months, and no generalized tonic-clonic seizures in the month prior to death. And additionally, half of the cases reported no evidence of a seizure immediately preceding SUDEP. And this speaks to the idea that recent seizure frequency and GTCs, which are considered the greatest risk factors for SUDEP in the general epilepsy population, may not be as great a risk factor in this syndrome. Interestingly, we also observed that a very high percentage, over 50% of our cohort, reported a recent illness. And by recent, this was generally within 2 weeks preceding their death. And while there were a variety of illnesses reported, both by witness statements and on autopsy, they were predominantly viral infections. And this prompted us to look into the literature to see what had been reported before about fevers and infections in SUDEP, and unfortunately, it seems to be a vastly underreported topic. So to summarize, what we've learned from this cohort is that SUDEP in our cohort in Dravet syndrome tended towards an early age of death, stable or improved seizure control, and relatively few generalized tonic-clonic seizures. And these findings suggest that there might be additional or unique risk factors to SUDEP in Dravet syndrome, while common factors such as the frequency of GTCs may not be as significant. We found a high prevalence of reported recent illness, which may indicate a novel SUDEP risk factor in Dravet syndrome. And together, we believe that these findings suggest that alternative mechanisms may contribute to SUDEP in this disorder. We will note that there's a limitation that this was not a population-based analysis, and so there may be a referral bias. And lastly, I'd like to point out that we hope to expand this work. We believe that there are more cases to identify within the data sets we're already looking at, and we hope to expand as well to additional data sets additional registries, and we hope to create a non-DS SUDEP cohort to compare to. And so with that, I'd like to thank Dr. Donner's group at Sick Kids in Toronto, Oren, Dan, and the team at Nasser, who have been tremendously helpful, and Dr. Sheffer at University of Melbourne. Thank you.
Microphone's not working. Any questions?
I see one here.
Yes.
Hold on.
It's okay.
Research tells us that many die face down from SUDEP. Over time, we find that not to be so true. My son was actually in fetal position when he passed away. And I think that that also needs to be addressed because a lot of young children that I have come in contact with their parents were not always face down. A lot of their heads were maybe caught in between the bed railings, but most of them were found in fetal position. So as you do your data, that would be also another way to consider that. Also, I like the point of you saying that things do occur as far as maybe a fever or infection. And I think that you expounded that maybe it was 2 weeks prior to SUDEP. It could also be months before that. My son was actually in the hospital May of 2019 with an unknown fever and infection. White blood count cells were sky high. 9/2, he was deceased. Whereas I constantly asked his neurologist to actually do a new EEG because the seizures began to change. She said she wanted to give him more time to heal. So it can be months prior that can also lead to SUDEP.
Thank you.
Other questions?
Mine may have just been answered because I didn't hear it before, but you said with the previous illness, what are the symptoms? Are there any patterns to the previous illnesses?
So the data we have on recent illness came both from autopsy reports, but mainly from witness statements. So parents who were talking about the condition of their child in the preceding weeks or month. There wasn't any pattern, any obvious pattern, and there were a variety of different illnesses that were reported, but generally they seemed to be mild, and in a few cases they had actually resolved in the week or two prior to the death.
Great talk. So I had a question about your data and was wondering if there were any near SUDEPs that were recorded. There's been a lot of talk today, about room sharing and the role of having a caregiver or somebody there for you. And so I was curious if the reason why there were, it looked like there were compared to other data sets, fewer SUDEPs occurring from seizures that emerged from sleep, and that might have been due to the fact that if those patients had a seizure in their sleep, there was a caregiver there to keep an eye on them.
That was one of our thoughts. We can't definitively say. So, it was very interesting and sad that of the whole 26 cases, the only 6 that died that were reported, and we definitively know they died while they were awake, were those in the group that said that they co-slept or room shared. So it's possible that there was some delay to that event or some prevention because of that behavior. We can't say for sure. And we don't know about those individuals who didn't respond.
So there are a number of things that are different than the literature that you pointed out. And so some of what you gathered, it sounds like, was by report. And so my question is really, how sure are we that the 50% that did not have a seizure actually did not have a seizure, or it just wasn't noticed? And that relates to the relationship to the possible viral infection in Dravet syndrome. Children are prone to having febrile seizure or having seizures with hyperthermia. And is it possible that they could have had a fever that nobody knew about, and then it led to a seizure?
I think you could ask that question forever. Yeah, we'll never know for sure in those cases. As to those that were reported as not having a seizure prior to the event, we based that off of autopsy reports where they looked at typical symptoms, such as if there had been cheek bites or if they were in certain positions, or if they died in bed, if the sheets were ruffled, these types of things. So I don't know, methods that had been used previously to decide whether someone had or had not had a seizure. But as we're not in the room, that's the best we can do.
It might be worthwhile doing a deep dive on that, because young children, infants in particular, can have seizures without a lot of motor activity, and you won't know that they had a convulsion. They wouldn't have had a convulsion. They may have just had a seizure that was without a lot of motor activity.
Absolutely.
If they're younger than 1, I don't know what your age. You did show the age distribution, but I can't remember how many of those would have been too young to have. So maybe the 1 or 2 year old.
Yeah. Thank you.
Good. Any other questions? We're doing pretty well on time. I congratulate you for staying on time, and that'll give me a chance to give you.
Excuse me. This way.
Ron.
Yeah. I have one question if we have time there. It's just to find out about the medications and how these patients were responding to medication.
It's a great question. I don't have the numbers in my head of like average medications or how many had switched within the last year. That is data that I believe we collected and have. Most of them were using, most of these cases were on multiple anti-seizure medications at the time of their death, and I do recall very few of them reported missing any of their doses in the preceding days. That's what I can tell you off the top of my head.
Okay, great. I'd like to give you this award for excellent research and mortality of epilepsy, and you get a magnifying glass for your future career in the field. Next speaker is Mojtaba Dayyani from the University of Texas at Houston, McGovern Medical School, Department of Neurology. He worked on his research with Dr. Samla too, and has now moved to City of Hope in Duarte, California.
Okay, hello everyone, dear participants, dear PAME family. It's a great honor and privilege to be here in your presence and having this precious opportunity to briefly present a part of our project on cardiovascular changes in partial and generalized convulsive seizures. This project conducted in the University of Texas under the supervision of Dr. Samla too. Okay, this is my disclosure. I hope you would be fine with the rest of it. We'll continue with this enthusiasm, and you all are here with this enthusiasm, I'm sure. Okay. So, as you know, there are a bunch of different autonomic dysregulations along with the seizures, like gastrointestinal, cardiac, respiratory function problems, and also recently in the literature we have seen some few case reports mentioning the blood pressure changes, especially hypotension, and really some episodes of increment in blood pressure, but mostly hypotension. So in this study, we aim to assess alterations of cardiovascular measures, around 9 or 10 of them, plus the respiratory functions. and correlate them with the with SUDEP severity markers and seizure severity markers. So let me tell you first this thing. The data from this study came out of a 7-year of data collection at the university hospitals in Cleveland and 2 years of data processing, signal processing. So in our study, we used a software, LabChart Pro 8, to analyze our autonomic signals, especially at the first level, we used the raw signal of the blood pressure to indirectly calculate the other measures that you see on the top of this slide. Inclusion criteria for our patients were those with intractable epilepsy, either generalized or focal convulsive seizures, who had been admitted for inpatient EEG monitoring, plus having presence of non-invasive continuous blood pressure monitoring for a prolonged period, which we defined it as more than 20 hours during the admission. Okay, here, this is just an overview of multimodal signal analysis we did with LabChart. You can see on the left, on the figure A, you see different channels from the top: EEG, cardiac output, stroke volume, total peripheral resistance, mean arterial pressure, EKG, heart rate, raw signal of the blood pressure, and abdominal builds. And this is how we could correlate the events together bit to bit and point to point quantitatively, meaning that for each point on this diagrams, we had the value of that point. And for instance, you see here in the orange box, you see an event of post-ictal hypotension, which is compensating in like 15 seconds. And also on the bottom of it, you see the blue part, which is the post-convulsive central apnea, which is correlated with that. Just another point here. On the top right, in the B diagram, you see the baroreflex sensitivity diagrams that we saw in all of our generalized patients. We saw a significant decrement of baroreflex sensitivity, basically the compensation of the body to hemodynamic changes after the seizure, which was decreased significantly after the seizure. And on the bottom, on the C, you see the power spectrum plots of HRV assessment. And the important point here was that all of our cases, generalized convulsive cases, had a significant decrement of low frequency, which was concordant with the decrement in our BRS values. Okay, let's briefly review the results. We had 811 consecutive patients, and after 7 years, we could enroll 15 generalized patients and 27 focal individuals with focal seizures, focal convulsive seizures. On the top, on the A diagram, you see 1 minute continuous blood pressure recording of this patient, these generalized patients. 3 of them out of 15 developed a consistent, almost consistent hypotension, either during the ictal phase or post-ictal phase, but we mostly focus on the post-ictal because, as you all know, the data in the post-ictal, coming out of the post-ictal phase are more reliable usually, although we also could capture the ictal phases like clearly. So on the bottom, you see 9 seizures out of the 51s of focal seizures, which is a little bit kind of new findings. It's around 22% of our focal seizures also developed hypotension, especially during the post-ictal phase. In terms of the duration of the hypotension, they were almost the same. Generalized patients had, in average, they had 33 seconds of hypotension, while the focals had 29 seconds in average. So it was not a big difference among them in terms of duration. But in terms of consistency with other autonomic dysregulation, there was a prominent difference between them, and generalized patients were more concordant, much more concordant on all of the other parameters and dysregulations. So here you see, on the diagram A, you see the modifications of mean arterial pressure, and the diagram B, you see heart rate. Diagram C, you see cardiac output, and diagram D, you see total peripheral resistance. One of the interesting findings that we found, basically, first we found 3 distinct patterns for generalized convulsive seizures, the hemodynamic changes, as you see with 3 lines. Those who had post-ictal hypotension are determined by the line red, which you can see that trough on the bottom of that dashed line on the diagram A. And the blue line, which was the majority of our cases, they had like the normal increasing pattern that has already been mentioned in other previous studies. And another new category that we identified were those with wide pulse pressure, meaning having remarkable increased systolic blood pressure and at the same time having a very low diastolic blood pressure, and which is correlated with the cardiac output of them on the diagram C, as you see, which is expected physiologically. Another finding here was that the response of heart rate were almost the same. As you see, they were continued to increase by the end of the seizure and continuing for almost 20 to 30 minutes, in average 30 minutes after the end of the seizure. And in terms of TPR, on the diagram D, you see that the highest value of TPR, the blue peak, belong to those patients who didn't develop post-ictal or periictal hypotension, which makes sense, again, because of a better autonomic response. Here we see the results of the same parameters, MAP, again, heart rate, cardiac output, and TPR, but for focal seizures. Here we found 2 patterns for them. Again, the red line represents those with post-ictal hypotension at the end of the seizure. The trough below the dashed line shows it. In terms of heart rate, they were almost the same, with a big difference with the generalized ones, that a sharp decrement after the increment at the end of the seizure. And in terms of cardiac output, they were pretty much the same, with just a little bit difference in the phase of them. And in terms of TPR, we saw a higher response, almost double response in those without post-ictal hypotension, which was pretty much the same as generalized ones. But one point, the value, the highest peak for the generalized patients was 4 times higher than the peak in focals. Okay, in conclusion, I want to summarize our major findings, basically. We found 3 distinct patterns for generalized seizures, for hemodynamic changes in them, and 2 in focal seizures. And all of our autonomic dysregulations were more severe in generalized ones. Also, we found that in generalized cases, we had a drop at the beginning of the seizure, which was about 25 millimeters of mercury, a kind of prodromal event that probably can predict the post-ictal hypotension for us, which is a completely new finding as far as we know. And the same thing for those who had wide pulse pressure, they had a beginning of an increment at the beginning of their trends, which was predicting another peak afterwards. And also, when we modeled our findings in a logistic regression model, we found that, unfortunately, as we know, younger age probably is more prone to develop post-ictal hypotension and probably getting involved with that autonomic storm of dysregulation. Also, in terms of breathing, we found that longer duration of hypoxia and also lower oxygen saturation levels and also post-ictal central apnea was evident in those with post-ictal hypotension, which was again concordant and confirming that turbulent time of dysregulation. And finally, we think that this multimodal evaluation can help to possibly detect patients who are at the risk of SUDEP. I hope you have enjoyed the major findings of us, and I would like to, at the end, I would like to thank my supervisor, Dr. Sandan Latu, and also our wonderful team in the University of Texas, and also the patients who cooperated with us with their participation and patience. And in the end, I would like to heartily dedicate this poem to all of you from 800 years back, and which our gathering today, right now, is a proof of this saying by Sadi. Thank you so much.
Thank you very much. We have time for a couple questions.
Really interesting. Cameron Metcalf, University of Utah. I just had a question about your mean arterial pressure data. I think you suggested that it was more a lower diastolic pressure that was driving the hypotension. I'm just wondering if what you think about the potential for pulmonary congestion or...
You mean the leading thing that resulted in hypotension?
Yes.
No, actually your answer has two parts. In those who had post-ictal hypotension, the leading factor we think that was related to the systolic blood pressure. But we had an exceptional group who developed wide pulse pressure. In those, we had an extremely low levels of diastolic blood pressure. So we should just distinguish these two things. Yeah.
So in that subgroup, so it's a subgroup of patients that tend to have the...
Yeah, it's a subgroup of them, basically.
Very interesting. Thank you.
Of course. Any other questions?
So you mentioned that preictal changes in blood pressure were predicted whether or not you might see changes in the autonomic output.
Yeah.
Post-ictally. Was that associated with changes in breathing preictally? Because as you probably know, there are patients that have preictal apnea.
We didn't capture any preictal apnea for those, but in terms of changes in blood pressure, it was significantly visible on the signals that we see a reduction of 25 millimeters of mercury from interictal to the 2 minutes before, right 2 minutes before starting of the seizure, which was interesting for us as well.
Okay. Well, thank you very much.
Thank you so much for your attention.
Congratulations.
Thank you so much. Thank you so much.
Our next speaker is Jiayang Liu and he is a postdoc of neural engineering in the Center for Neural Engineering at Penn State. And
Good afternoon, everyone, and thank you very much for inviting me to share what I did in the past several years. And basically, I focus on the tissue oxygenation dynamic study in the spontaneous seizure and related SD events in a rat model of temporal lobe epilepsy. So the SD events, formerly called spreading depression, was discovered in 1944 by Liu when he was examining the ECOG signal of an epileptic rabbit. And he found this almost completely electrical silencing propagating in the cortex from one pair of electrodes to the next one. And he named it spreading depression. So as you can see, spreading depression should be closely related to epilepsy, but it's almost forgotten by the community until in 2015, Dr. Nobels found SD may play an important role linking seizures to SUDEPs. So Dr. Gluckman lab have observed SD event in both mice and rat model. And this is an example from a rat prepared under the tetanus toxin of temporal lobe epilepsy. So we have 6 depth electrodes targeting the hippocampus as shown in the red part. And on the top, you can see this is a typical seizure signal. And then suddenly you have this kind of silencing. If you examine the DC component of this signal, which shown the several rows down there, you can see the propagation of this big negative DC shift. So this marks SD events. So usually the animal prepared by this toxin model will go one of these 2 evolution pathways, from normal state to seizure and then to post-seizure, or from normal state to seizure to SD and post-SD. The mechanism behind these transitions may involve like excitatory or inhibitory imbalance, or the tissue oxygenation regulation breakdown. Theoretical work has pointed out the tissue-level oxygen concentration behave an important role, especially in the interaction between seizure and SD event. So we want to ask the question, does local tissue oxygenation lead or follow these transitions? We implemented a long-term continuous monitoring of 16-channel biopotentials of EEG and a synchronized oxygen sensing using this recording system. So it is small and light enough and can be put on the head of the rat. And the animal can behave freely in a cage. Even during the process, we change the cage. So we capture the spontaneous seizure and seizure-related SD events. When we do the tissue oxygen sensing using an electrochemistry way, lots of researchers turn to the constant potential amperometry method, the CPA measure. This measurement, basically, you apply a constant potential across the working and reference electrode and measure the response current. So this CPA measure is a mixed result of both the local oxygen concentration and oxygen diffusion coefficient. And they further assume the oxygen diffusion coefficient to be constant. However, we know during the SD propagation, there will be a significant cell swelling phenomenon, which will shrink the extracellular space and change the tortuosity of the extracellular space. This volume and the tortuosity change will affect the oxygen diffusion process in the extracellular space. So we implemented another method called long-term pulse voltammetry method. We apply a pulse potential and measure the response. There's 2 features within each pulse. One is the peak value, the PV, which is almost only dependent on the local oxygen concentration. And the other one is the peak flat value, the PFV, which is comparable to the CPA measure and depends both on the concentration and the diffusion coefficient. So using these two values, we can extract the diffusion coefficient and characterize the local concentration and the diffusion coefficient separately. So we have two important conclusions. The first one is that the local tissue oxygenation or local oxygen concentration behaves as a following role during the peri-seizure and peri-SD transition. Or we can say there's no significant tissue oxygenation regulation breakdown before seizure onset or before SD onset. And we found that the extracellular space shrink behave as a leading role in the transition from spontaneous seizure to SD events. It may, we can say in other words, it may induce SD events in the spontaneous seizure. I would like to thank you all the faculty members and students in Penn State who contribute to this work. And thank you very much.
Any questions? So I have one. So this question of what's exactly happening during spreading depolarization and the oxygen dynamics is really important, and this is very technical and excellent work. With your method, are you able to measure the absolute levels of oxygen, and do you know what how low it goes during spreading depolarization?
Oh, it is excellent question. So usually when we use this single electrochemistry way, we can only measure the relatively change of the oxygen level. And I know people, they use optical way that can measure the absolute value of oxygen. And I compare the work, my work to their work, and show similar dynamics. But again, we cannot measure the absolute value of oxygen.
Okay.
Yeah.
And another question, what we care about as neurologists is recovery. And so what happens after the spreading depolarization to the oxygen levels? Is there a long lag before it goes back up to normal, or?
No, it's not a very long process. Usually during several minutes, the oxygen level will go back to the baseline.
Okay.
In our model. Okay. Yeah.
Dr. Liu, I know that we're talking about spontaneous seizures and seizures depolarization. My question is, when it comes to having EEGs done, should it be a random time clock to have it done versus having it done sporadically, and in hopes of that, of trying to alleviate those who may be facing SUDEP?
Oh. So let me repeat your question. You try to say that if this kind of SD events will maybe relieve the SUDEPs, is that the question? So in our rats model, we prepared under tetanus toxin. So when the animals start to get spontaneous seizure, during the first 5 to 10 days, it will have a lot of SD events related to the seizure. And after this, maybe 10 days, there's almost no SD events involved. So the animals have less seizure, less events, less SD events too. So it's very hard for me to say that if we did something to make these things go. I think it's just a model. Our model cannot maybe answer the question after the first 10 days, I would say. Yeah.
Yeah, I don't have that, so maybe you could ask it if you got a microphone there.
Thanks. Cindy Mitchell, thank you for your question in the chat. So the question is, so for parents at home,
Okay.
are there non-invasive ways to monitor for tissue hypoxia at home, Or aren't we there yet? Is this still a research only?
Okay,
Thanks.
so before this in vivo experiment I did acute surgery when I measured the blood oxygen level and this tissue oxygen level at the same time. So these two dynamics correlate with each other very well. So basically, but we cannot say in vivo, because in vivo we have a normal oxygen regulation. Acute surgery, we do not have this normal regulation. So what I can repeat the acute work I did. So we measured the blood oxygenation level and the tissue oxygen level at the same time. And then we put a cone on the nose of the rats and we turn off the oxygen supply. So you can see a clear decrease of the blood oxygen level. And at the same time, the tissue oxygen level decreased almost the same time. So, but in vivo, I'm not sure if there's in vivo some other mechanism. Even during this blood level decrease, the oxygen level, tissue level can still constant. So for the parents to using the blood oximeter may be a good idea.
These are tissue, focal tissue hypoxia, and yeah, I'm answering the person. And it would be an invasive method, so that would not be possible at home.
Yeah, tissue is not possible. Yeah.
Okay, thank you very much.
Thank you.
It was very interesting.
Okay.
Our next speaker is Benjamin Owen, who is a staff scientist at Vanderbilt University Medical Center. And he works with Dr. Nobis. Welcome.
Thank you, Dr. Richerson, for that kind introduction. Thank you, everyone, for coming to my talk this evening. As you heard, my name is Dr. Benjamin Owen, and I'm a staff scientist in the Nobis lab at Vanderbilt University Medical Center. And tonight, I'd like to talk with you about some of the work we've been doing where we interrupted synaptic outflow of a specific extended amygdala nucleus and how that reduced seizure-related death in an audiogenic mouse model of SUDEP. So, SUDEP is a major cause of mortality in refractory epilepsy patients, and in the literature, it is suggested that seizure-related respiratory dysfunction may be a part of an initial cascade of events towards cardiac and respiratory arrest and death. It's also been suggested in the literature that previous reports suggest that the amygdala and the extended amygdala play a possible role in SUDEP, in particular the central amygdala, where lesioning experiments in the amygdala and central amygdala have increased the survivability of an audiogenic seizure mouse model, the DBA1J mice. Now, this is interesting because the central amygdala is highly interconnected with another region of the brain, the bed nucleus of the striae terminalis, or the BNST as I would call it from here on out. And the BNST projects to brainstem respiratory centers such as the parabrachial nucleus and the periaqueductal gray. And this led us to hypothesize that the BNST will play a significant role in respiratory dysfunction related to seizures. And if we can inhibit that BNST synaptic input to those brainstem respiratory centers, we can increase the survivability in this audiogenic seizure mouse model. So our first question was, what regions are activated following seizure-related respiratory arrest? And to do that, we took male and female DBA1J mice and we primed them to have audiogenic seizures by exposing them to a broad frequency loud tone until the mice had 3 convulsive tonic-clonic seizures or for 3 to 7 days. Following this priming period, we then re-exposed the mice to the same tone and observed whether they had tonic-clonic, wild running, or no response. We would wait 90 minutes, sacrifice the animals, and collect tissue from the dorsal bnst, the central amygdala, the periaqueductal gray, and the inferior colliculus. And then we would use immunohistochemistry to observe the levels of a neuronal marker for activity, CFOS. And what we observed was the tonic-clonic seizure mice had a higher level of that neuronal activation marker compared to the mice who experienced wild-running seizures or had no response to the tone at all. And we can see that in this example where the bottom mouse, the tonic-clonic mouse, had that higher expression of CFOS in the dorsal bnst. We did not see any differences in CFOS expression in the central amygdala, but as positive controls, we included the periaqueductal gray and the inferior colliculus, which both had high levels of CFOS as reported previously in the literature. Now, this led us to our next question. If we inhibit the bnst, will that improve the survivability of these mice? So, once again, we took a new cohort of male and female mice, primed them as before, only this time after the priming, we injected the dorsal bnst with a virus either containing tetanus toxin or green fluorescent protein. And we waited 3 weeks for the virus to replicate. Following that period, we then re-exposed the mice to the tones that we used for priming, and we observed whether the mice were, we observed the mortality. And what we observed was that in the tetanus-injected mice, the survival rate was 42% versus 8% for the control mice. And this led us to ask, is that due to any respiratory changes? So, once again, we took another cohort of DBA1J mice, primed them, injected them, waited 3 weeks, and this time we performed whole body plethysmography, or recorded their respiratory characteristics. And we did this during baseline respiration. We did it during exposure to a hypercapnic or higher CO2 environment and a low oxygen or hypoxic environment. And surprisingly to us, we observed no changes in their respiration, or little to no changes in their respiration. Either with minute ventilation or respiratory rate. In fact, really the only change we observed was an increase in the tidal volume during hypercapnia. So this led us to conclude that really there was little to no change in their respiratory behavior following bnst activation. So our next question was, if that's the case, could the changes be due to alterations in the synaptic circuitry between the bnst and those brainstem respiratory regions? And for that, what led us to that question was, going back to the mortality data, we had observed when we recorded synaptic events, postsynaptic events in these transfected dorsal bnst neurons, that there were fewer postsynaptic events in the tetanus-injected mice than in the control. So, what we did was, again, another cohort of male and female DBA1J mice, primed them, injected them, waited 3 weeks, and this time we collected tissue from the peribrachial nucleus and the periaqueductal gray. And I performed whole cell patch clamp electrophysiology to record spontaneous excitatory and inhibitory postsynaptic events. And what we observed was in the mice with the inactivated bnst, there were smaller excitatory postsynaptic currents in the peribrachial nucleus, meaning that there was a decrease in the excitatory signaling from the bnst to the PBN. There was a trend towards a decrease in inhibitory signaling, but again, that was only a trend, not statistically significant. Meanwhile, when we looked at the distribution of events, there was a shift in both the excitatory and inhibitory signaling to be smaller, and in the inhibitory signaling to be less frequent. This is completely opposite of what we saw in the periaqueductal gray, where we saw no change in the average amplitude or frequency of these postsynaptic events. But we did, however, see an increase in the inhibitory signaling to the periaqueductal gray. So, in summary, What we observed was that the bnst is activated by these tonic-clonic convulsive seizures in the DBA1J mouse model. And we observed that if we inhibit that bnst synaptic signaling to these brainstem respiratory centers, we can increase the survivability of these mice with little to no change in their respiratory behavior. We also observed that if we inactivate that bnst synaptic output, we get an overall decrease in the excitatory signaling to the parabrachial nucleus, whereas in the periaqueductal gray, we get an increase in inhibitory signaling. And this is leading us to a few ideas for some of these future experiments, including looking at top-down modulation. Again, the bnst is highly interconnected with that of the amygdala and the central amygdala. So what is that influence causing with the bnst? What are some of the regions like the medial prefrontal cortex, which also sends signals to the amygdala? How is that affecting the bnst and this role in respiratory arrest following seizures? With the periaqueductal gray, that increase in inhibitory signaling, did we somehow cause that increase in inhibition by turning off other signals to the periaqueductal gray that also inhibit it? And of course, what are the influences of different neuromodulators, serotonin, dopamine, norepinephrine, oxytocin? And with that, I'd like to acknowledge my PI, Dr. William Nobis, who took me from a background of primarily hippocampal and medial prefrontal cortex electrophysiology into the amygdala and the bnst. Winwei, our research associate who optimized our injection protocols, and our undergraduates Maya and Jeremy, who were instrumental in the plethysmography, the priming, and the immunohistochemistry. And with that, I will take your questions.
So I'm going to take the chair's prerogative and ask the first question. So I would interpret your respiratory data differently, and that is because it's known that if you completely isolate the medulla or the pons in the medulla from the rest of the brain, breathing is really unaffected. It's not affected by the cortex, which is gone, but it's not. It's baseline breathing. Baseline breathing is normal.
Okay.
And so, what you've shown is that by preventing outflow from the bnst and central amygdala, that you don't get a change in baseline breathing, but you didn't look at what happens to breathing during a seizure. And that would be, in my expectation, that would still occur, that there would be inhibition of breathing during a seizure because you've lost the connections from the amygdala down to the brain.
Right. We are actually trying to do those experiments now. We've had to get some new equipment to allow us to do this. Unfortunately, the chambers we used for the respiration were not conducive for playing the audio tone to the mice to record at the same time. We have gotten some new equipment to do that now. Hopefully, after this conference, we'll have that data ready for hopefully next year.
Because that's what you want to know is how do seizures affect breathing, but the baseline breathing is really not relevant to the question of why you get apnea during a seizure.
Gotcha.
Is there another question?
George, you took my question, but great talk, Benjamin.
Okay. It's a question over here. There's a couple questions.
Okay.
So I have a question for you. Basically, when you silence all the neurons from the bnst, you are able to 42% of your mice keep alive, right? But what happened with the other ones who died, with the other 58%? Is it because you were unable to silence all those neurons, or is it because it's another mechanism behind?
So it could be due to with the injections, there's always going to be a little bit of variability, either in expression or which neurons have been transfected with the virus. So it's possible that in the other 58%, we just didn't hit the neurons that were conducive for survivability. We are trying to, with some of these future experiments, see if we can get maybe a subpopulation that is important for this, or Is it that it's based more on a different type of phenotype for these neurons that we can maybe try to target? Right now, it's a little unclear even whether some of the survivability is from that change in excitation or inhibition. So it could be with the 58%. If the excitation's more important, we didn't get as many excitatory neurons and we hit more inhibitory neurons, or it could be vice versa. It's still a little early for some of this analysis, but that is something we are trying to drill down into.
Actually, I think, did you have a question, Steve?
I believe the...
He had his hand up earlier, but
oh, I'm sorry.
that's okay. Go ahead. I was trying to go in turn,
Oh, I'm sorry, I didn't see.
but he put his hand back down.
In your analysis, have you noticed a connection between the male rodents as far as like DNA or genetics, and as well as also for the females? Is it something that really has stood out to you as you do your research that will actually show you a little bit more evidence of what happens before SUDEP actually takes place?
I'm sorry, could you repeat the question just one more time?
In your analysis, as you're doing your studies, when you're doing the male specimens and you're looking at the genes and the DNA, is there something in connection or relations that actually shows you a connection of things that's going on before it leads to SUDEP? Is there some finding of specimens that you have some correlation with?
So we haven't gotten down into the sex differences yet with these sets of experiments. That is something we are interested in. We do have at least the electrophysiology data that we're still trying to get through for that. Once we have a clearer picture on what the electrophysiology data looks like, we will definitely be trying to get a little bit more into some of those mechanisms between the sexes, if there is a difference between them in this model that we're using. Yes, sir.
Any other questions? More questions? Not, thank you very much.
Thank you. Thank you. Thank you.
Okay, our next speaker is Mariam Syed, who is a postdoctoral research fellow at Wayne State University and is going to give us a talk on health services research.
Is this, okay, got it. Good evening, everyone. It's really nice to be here. My name is Mariam Syed. I am a research fellow at Wayne State University, Detroit. First of all, I would like to thank PAME for inviting me to share my study. Today I'll be presenting my study titled Understanding the Effect of Hospital Safety Net Burden on Inpatient Outcomes Following Status Epilepticus. As for my disclosures, I have none. And today, firstly, I will explain what I mean by safety net hospitals and why the safety net burden of the hospital matters when it comes to inpatient outcomes. What was our study's objective, the methodology that we used, our results and conclusions. So a safety net hospital, our hospitals are facilities that are legally obligated to provide care to patients regardless of their insurance status. So in essence, they practice an open door policy, and these hospitals are usually located in underserved areas. They serve a large population of uninsured patients or patients on Medicaid, and they also serve large populations that come from racially and ethnic minorities, and they can be either government-owned or private facilities. So why does the safety net burden of the hospital matter? Well, firstly, research shows us that patients' experience or how patients feel about being treated at the hospital is much worse for safety net hospitals compared to other private facilities. This paper by Chatterjee et al. From University of Pennsylvania showed that for all safety net hospitals in the United States. And this is also true for inpatient outcomes, especially for surgical procedures. This study looked at management of traumatic brain injuries, other hemorrhagic diseases, emergency medicine admissions, and common acute medical conditions such as myocardial infarction. And the reason why this is concerning is because, like I mentioned, the hospitals, since they serve underinsured patients or uninsured patients, it is expected that these patients are generally sicker. They're predisposed to worse outcomes and worse comorbidities. And self-reported poor patient experiences are already associated with slower recovery and lower likelihood of adherence to medications. And since these hospitals already function on low or negative profit margins, if they fail to meet the standards of care that is expected from them, they risk losing fundings or risk being penalized for it, which could actually lead in worsening disparities in access to care for vulnerable populations. So I like to think of it as a vicious cycle where because of the high caseloads and poor or lack of resources, if we do not give the care the patients deserve, and that leads to worse patient outcomes, the hospitals might risk losing funding, which would lead to them, not getting, experiencing budget cuts and not being able to provide that care, which again would lead to worse patient outcomes. And the reason why this is so important is, as of 2014, 25% of the hospitals in the US account as safety net hospitals. So the objective of our study, first we identified that most of these studies focused on surgical process and acute medical conditions, and we did not see any studies looking at the safety net burden of the hospital and its impact on inpatient outcomes for status epilepticus. And status epilepticus is a common neurological emergency. If you don't have epilepsy preceding, there is a risk of developing epilepsy of 22 to 40% after experiencing a status epilepticus, and in adults, the mortality can be as high as 57%. As for our methodology, we use the National Inpatient Sample, which is the largest publicly available database and provides us access to regional and national estimates of inpatient utilization, access and quality and outcomes. We identified around 137,000 patients with status epilepticus between the years 2005 to 2014. And then we use this validated equation for the safety net burden, which you can see in the purple box, number of Medicaid and uninsured patients divided by overall all patients. And we were able to stratify our results into low, medium, and high burden hospitals. For analysis, we use a multivariate logistic regression analysis, and we control for factors such as age, gender, race, median household income, insurance status, comorbidities as defined by the database, and the hospital level characteristics, so we could isolate the effect of safety net burden on the impact of inpatient outcomes. And for the purpose of the analysis, we use the low burden as our reference point. So this is just a brief overview of our patient demographics. As you can see, the highest burden hospitals mostly saw younger patients aging from the ages of 18 to 35. Unsurprisingly, around 51% of the patients were Medicaid and 22% were uninsured for high burden hospitals. We had a mix of racial and ethnic representation, and 48% were from the lowest quartile of median household income, which were seen at safety net hospitals. As for the hospital characteristics, most of high burden hospitals were urban teaching hospitals. Moving on to complications. Both medium and high burden hospitals had high rates of pneumonia. High burden hospitals also had high rates of renal complications. We saw high incidence of cardiac complications in both medium and high burden hospitals, high rates of pulmonary complications in medium burden hospitals, and significantly lower rates of neurological complications in both medium and high burden hospitals. Metabolic complications were also significantly high for medium and high burden hospitals, and so were hematologic complications. There are some limitations that are associated with using the national inpatient sample, since we use the ICD-9 codes to isolate the pathologies. There might be coding errors, and we do not have access to granular clinical information such as seizure type, etiologies, which drugs were given, what were the doses, and whether there was neurocritical expertise present at these hospitals. And we cannot differentiate between readmissions and patients or unique patients, and we can only look at inpatient complications. We cannot look at long-term complications that these patients experience. But despite that, it is a very large database, and it can give us a really good idea of which complications to look out for. In conclusion, higher safety net burden of hospital is associated with greater rates of complications in patients admitted for status epilepticus. And in order to provide equitable healthcare to patients, it is very important to address these findings so we can do our best taking care of these patients. Thank you.
Thank you. That's so interesting. I really appreciate your talk. Thank you. Do we know if the reason there are higher rates of complications is because they come in sicker, because the patients are less likely to have good kind of routine health care prior?
That's a really good question. I would like to reiterate that we controlled for all comorbidities in our analysis so it doesn't influence inpatient outcomes. So we use the Alex Hauser Comorbidity Index, which is provided by the National Inpatient, and we did control for them. So it's hard to say whether the impact, from our analysis point of view, which doesn't.
You did your best to control for them.
Yes.
In addition, do you know about the duration of status epilepticus, presuming that people who have longer seizures definitely would be higher risk of pneumonia, renal complications than others?
Unfortunately, that comes under the granular clinical information that we would love to have, and that would give us so many more answers, but we don't have access to that.
So you can't really determine whether it's the care delivered or something more intrinsic to the condition or the patient, right?
No, we do have the length of stay variable, where we look at whether, and it's defined as stay at the hospital longer than 3 days, and that was not significant for this study.
Not significantly different.
I'm sorry?
Not significantly different
Yes,
between hospitals?
for high burden hospitals.
Thank you, really nice.
Thank you.
Did you tease apart data between rural and urban?
I'm sorry?
Did you tease apart data for rural versus urban sites?
Yes, we did, and I think I mentioned in one of my earlier slides that most of these medium and burden high hospitals were urban teaching hospitals, and we did control for that as well.
Maybe I missed it, but was this overlapping the period of COVID, and was there a change that occurred with status epilepticus?
No, so this database, the one we use, the ICD-9 codes, which is from 2005 to 2016, there was no COVID, fortunately, back then, yeah.
She has 4.5 minutes. I don't want to cheat her. But, actually, so I have to thank the speakers, trainees. If this continues through your career, you're going to be a lot better than the senior investigators who tend to go over. So you did a good job of staying under. We do have time for one more question, if anybody.
Dr. Frieda, as we're talking about the serotogenic mechanism, when we think about that, we know that that has a lot of issues that research is still being done on. But I think that I feel that also needs to be addressed is a lot of times with the parents and caregivers of children who actually take seizure medications, a lot of times the parents know what works and what doesn't work for their children. And when they go before the physician and they ask the physician for better medication or to continue on with the medication that they feel is helping their child, a lot of times we are accused of taking our children's medication. Is that something that you guys are planning on to address in the near future? Because there are so many parents who stand in the gap to advocate for their children to make sure that they're getting the best of care, but then it turns back on them like they are drug abusers.
That's a great question. I cannot speak to that using our recent findings and the database that we've used because this is highly specific knowledge that I would think would require a lot of investigation into what happens at the intake process at the emergency center. So unfortunately, I don't have the answer to that, but I think it's a really good conversation starter and something we should definitely look into. Thank you.
Okay, thank you.
Thank you so much. Thank you. Thank you.
All right, our last speaker is Frida Turan Garza, who is just obtained her PhD from the University of Iowa in neuroscience 2 months ago, and is now completing her requirements for an MD degree.
Hi, everyone. Thank you for being here, and thanks for those tuning in online. First of all, I want to thank the PAME committee for putting this together and for giving me the honor of being able to chat with all of you today. So the title of my talk is Seizures Cause Prolonged Impairment of Ventilation, CO2 chemoreception, and thermoregulation via serotonergic mechanism. However, today, because of time constraints, I'm going to be focusing on ventilation and CO2 chemoreception. So the nice thing about being the last speaker tonight is that all of you have been primed to listen to my talk. And I'd say that the biggest takeaway that we can all think about is the pathophysiology of SUDEP is extremely complex. However, one thing that everyone here has already heard about from previous talks is that SUDEP has been linked with serotonergic dysfunction. And in fact, there's plenty of compelling evidence from animal studies that show that following seizures, serotonin neurons are inhibited. When serotonin neurons are inhibited, this has a negative impact on respiratory control, certain aspects of it to be specific. And one of these is CO2 chemoreception. Here I'm showing you some data that was obtained by Drs. Roop Sanju and Brian Gelbach from the University of Iowa. This is unpublished data. And this is from epilepsy patients. And they showed that seizures actually cause a prolonged blunting of CO2 chemoreception in some of these epilepsy patients. So just to guide you quickly on some of these graphs, which my pointer doesn't really work, but the graph on the left is showing minute ventilation on the y-axis, and on the x-axis we have end-tidal CO2. So this is in one epilepsy patient that they had the minute ventilation or the ventilatory response recorded in response to increasing levels of CO2. The blue line represents the interictal response, meaning before a seizure occurs, and the red line represents the response that was recorded approximately 3 hours after this patient had a generalized tonic-clonic seizure. The graph on the right of that is a summary of 4 seizures that were recorded from 3 patients. So the interictal, once again, before the seizure occurs, we see kind of a normal distribution of a proper response to CO2. And the postictal response, once again, these patients, after generalized tonic-clonic seizures occurred, it was about an average of 3 hours after the seizure, they repeated this measurement, and I hope you all can appreciate that postictally, this response to CO2 was diminished. And so this led for us to ask the question, how exactly do seizures affect this important aspect of respiratory control, which is the hypercapnic ventilatory response? And so our goal was to use animal models, specifically mouse models of epilepsy, to explore or to determine how seizures affect CO2 chemoreception by measuring the hypercapnic ventilatory response, and what role does serotonin play in all of this? Because as some of you may know, the serotonergic system plays a role in a lot of important physiological functions, but one of the most important ones is respiratory control. Oh, it's not working.
Can you advance the slides over there? She can't.
Yeah. What? Oh, okay. Now it's working, and it revealed all of my results at once. Going back, methods. So, like I mentioned, we used 2 models of epilepsy. So these are 2 genetic mouse models that have mutations in the SCN1A gene, which encodes for a voltage-gated sodium channel. These mice are supposed to model Dravet syndrome mice. So throughout my talk, I'll refer to them as Dravet mice. And the second mouse model is SCN8A mutant mice. And these mice have a gain-of-function mutation in another, a different sodium channel. And I'll refer to these mice as D+ mice. These mice are supposed to model a very severe form of epileptic encephalopathy. And so, like I said, I'm glad this is the last talk. You guys have already heard about whole body plethysmography. And so here in my experiments, I measured the hypercapnic ventilatory response, which I'll refer to as HCVR throughout the rest of the talk, before and after inducing seizures in these 2 mouse models. And this was done in awake, unrestrained mice, and using the system that we have there. We exposed them to 2 levels of CO2, 0%, which is representing normal levels, and 7%, which represents hypercapnia. Finally, to explore the role that serotonin could be playing in this, we first depleted serotonin using PCPA. So PCPA blocks the synthesis of serotonin, and this we've shown in previous studies from our group that treatment with PCPA for 3 to 5 days effectively lowers the levels of serotonin in the brain to about 20% of what the baseline level should be. And finally, everyone, or not everyone, but most of you may have heard of fenfluramine. That is the most recent FDA treatment for seizures and Dravet syndrome, I believe as of last year. And so we use fenfluramine to shift serotonin to the other way and increase serotonin release. So for my first set of results in Dravet mice, I first obtained the hypercapnic ventilatory response in both mutant mice and wild-type littermates. And I compared it between those 2. This is without a seizure occurring, and as you can see here, once again to orient you, the y-axis is minute ventilation, and the x-axis is this response to 0 and 7%. And as you can see here, there wasn't a significant difference between these 2 animals. However, in Dravet mice, you can induce seizures with heat or hyperthermia, which is what you see in Dravet syndrome patients. And when you repeat this, we see that this response has actually been impaired in mutant mice. Of note, wild-type mice were heated to the same temperature, but these mice, none of these developed seizures. So what this is showing is that this is a seizure-specific impairment that occurs in these mice. And so this was for one group of mice. We decided to further explore this with more cohorts of mice, and we found 2 different, or I guess 2 groups of responses. About half of these had a very severe impairment of the HCVR following seizures, as you can see on the red trace. This is just an example. For the blue trace, that is representing the other group of mice, which had a more mild response to seizures, where the postictal response to CO2 was not as impaired as the red group. And when we compare both of these groups, we see that the severe group had indeed a very severe depression to 7% CO2. However, also at 0% CO2, in other words, normal ventilation following the seizure was severely impaired in this group. And in terms of the mild group, we see that there was some impairment, but I hope you can appreciate that it was not as severe as in the red group. And so we asked, is this unique to Dravet syndrome mice? And so we used our D+ mice. Like I said, this is a different mouse model. And note, both of these have a high incidence of seizure-induced death. And so for these mice, interestingly, we, with some of our collaborators, we were told that we can also induce seizures in these mice. And this is kind of a fairly new finding. And so in these mice, we can induce seizures by using an audiogenic stimulus to stress them. And so we recorded the Periictal HCVR response, induced a series of 4 seizures with an audiogenic stimulus, and then repeated this experiment. And as you can tell, postdictally, these mice also show an impairment of the HCVR. So just to quickly summarize this, Dravet mice displayed blunted HCVR following induced seizures, and D+ mice also display an HCVR impairment following audiogenic seizures. So the common denominator here is that this is a response that happens after seizures, whether they are hyperthermic seizures or whether they're induced differently. Next, these results are just in Dravet mice. We depleted serotonin in these mice with PCPA, and we measured the slope of this HCVR response starting. As you can tell, both groups were properly randomized. And after 4 days of PCPA treatment without inducing seizures, we see that we were able to mimic the effect of seizures on mice that were treated with PCPA. And after these 4 days of treatment, then this same group of mice were subjected to hyperthermic seizures, and we did the same as what I did in the previous slides. We measured the response before and after. And as you can tell, in the vehicle-treated group, the response was also decreased. And we also saw a similar decrease in the PCPA-treated group. However, the degree of this impairment was not as severe. And so what this is suggesting is that PCPA treatment partially occluded this effect that seizures have on the HCVR. Interestingly, we did this in several mice, and unfortunately something that happens with these experiments is that a lot of these mice die from the seizures, but I started to notice a trend in which vehicle-treated mice, about 20% of them, so in this case, 8 out of 41 mice died following a seizure that we induced. However, with PCPA animals, 21 out of 48 of my animals died following seizures. And some of these animals actually died after 3 days of being treated, so I didn't even get to study them because they died spontaneously. And so, just to quickly summarize this, depleting serotonin with PCPA mimicked the impairment on the HCVR that seizures have, and also partially occluded this impairment and increased the seizure mortality. Next, we used fenfluramine, repeated the experiments, got a before and after a seizure induction, and we saw that fenfluramine was able to ameliorate this impairment. And a different way of looking at this is at the minute ventilation plotted against the response to CO2. And I wanted to show it this way specifically so that you could appreciate that mice that were treated with fenfluramine, the response to CO2, or the HCVR in this case, was not as impaired in mice that received a vehicle. So this almost suggests a protective effect on this end. And so just to quickly summarize, fenfluramine improved the postictal HCVR in these mice and even baseline ventilation. And unfortunately, I don't have time to go over the postictal thermoregulatory findings, so we did see some changes in body temperature in Dravet mice after seizures, and we saw some significant effects with PCPA and fenfluramine that I'd be happy to talk about if you come see my poster on Monday, or if you want to ask after this session. So just to summarize, seizures impair CO2 chemoreception in epilepsy patients and in 2 mouse models of epilepsy. This is consistent with the hypothesis that seizures could be inhibiting serotonin neurons, which would cause prolonged inhibition of baseline ventilation and CO2 chemoreception. These postictal ventilatory abnormalities could represent a biomarker for those that are at higher risk for SUDEP and could also be the primary cause of death in some SUDEP cases. And finally, fenfluramine ameliorates the effects of these seizures on baseline ventilation and CO2 chemoreception, and that's what we've been seeing, at least with this preliminary data. And with that, I'll be happy to take questions, but I'd like to thank all of the people in my lab. Like Dr. Richerson mentioned, I just defended my thesis, so I had to include my committee. And as well, I'd like to thank our collaborators and our funding sources. Thank you.
All right, we have time for just a couple of quick questions. Frank? Oh, I have to get a microphone.
Good work, Frida. I have a quick question. When exactly did you take the measurement in your postictal response?
That's a good question. So I try to stay, I did my best to stay consistent. So all of these measurements were taken approximately 10 minutes after the last seizure in my mice.
Were you also consistent with that time for the treatment cases when you give them fenfluramine and so on?
Sorry, can you repeat the question? I
For
couldn't hear you.
fenfluramine, were you able to maintain that time point, or did you need a little bit more time to get the drug to appropriate level before you test?
So the way that I was able to stay consistent with the measurements and to allow for the proper gas levels to be reached, we were able to change the flow rates to be able to reach the gas levels that we were hoping for. And that was what helped me be able to do the 10-minute point. However, something that I'm not showing you here in this presentation is that in addition to 10 minutes, I also checked 30 minutes and an hour, up to an hour after the last generalized tonic-clonic seizure. And some of these responses actually remained depressed more than an hour after. But just for the sake of consistency, since the first set of experiments I did just 10 minutes, that's why I only showed the 10-minute data.
Yeah, thank you. Very nice.
Very quickly, did fenfluramine have any effect on seizure severity or duration?
That's a good question. So we're still in the process of collecting the data, and I'm not done quantifying the data, but what I can tell you by observation, because I recorded all of these seizures, is that as I'm heating up the mouse slowly to reach the seizure, I record the temperature at which the first seizure occurs. However, something that like a key point that I try to reach here is that all of the animals reach a generalized convulsive seizure or a Racine scale 5. So this is one of the most severe type seizures. And so what I noticed is that my fenfluramine treated animals, it took a lot longer for me to be able to reach that. And in some cases, there were a few animals that never reached that, and they were heated for such a long period that I didn't actually end up including them. But I did notice, for the most part consistently, that it was harder for me to reach that temperature threshold at which mice reached a generalized convulsive seizure. But like I said, I haven't actually quantified that data because my N is still low, but that was definitely something that stood out.
Okay, thank you.
Sorry.